Hello, and welcome to today's HealthITAnalytics.com presentation, The Value-Based Return on Creating a High-Quality Data Pipeline. My name is Jennifer Bresnick, Director of Editorial at Xtelligent Media, and I will be moderating this webcast, which is brought to you by Looker. Looker is a complete data platform that offers data analytics and business insights to every department and easily integrates into applications to deliver data directly into the decision-making process. The company is powering data-driven cultures at more than 1,200 industry-leading and innovative companies such as PDX, Council, and Grand Rounds. After a presentation by our speaker, we will conclude with a question and answer segment for the audience. Audience members are free to submit questions at any time during the presentation using the question tool to the left of the screen. If you are having technical difficulties during the presentation, please make sure that you are using the latest version of Flash. For any other issues, click the Help icon at the top right-hand corner of the screen. A copy of today's slide deck will be available following the presentation. You will receive an email after the event with more details. Today we are pleased to welcome Bill Gillis, Chief Information Officer for Beth Israel Deaconess Care Organization, otherwise known as BIDCO, a value-based physician and hospital network and accountable care organization based in Westwood, Massachusetts. In his role as CIO, Bill leads health IT innovations that support BIDCO's network of 2,500 physicians and 8 hospitals in the delivery of high-quality, cost-effective care. Bill has worked in health IT for more than 20 years and specializes in EHR and HIE interoperability strategies, technologies, and deployments. Working directly with John Halamka, CIO of Beth Israel Deaconess Medical Center, Bill led the team that deployed the first ambulatory EHR system for BIDMC affiliates in 1997. We will now begin our presentation, so Bill, the floor is yours.
Greetings, everyone, and thank you to Xtelligent Media and Looker for allowing me to give this presentation. So again, my name is Bill Gillis. I'm the Chief Information Officer for Beth Israel Deaconess Care Organization, and we are affiliated with Beth Israel Deaconess Medical Center. And I'm hoping today to talk a little bit about our data journey and what we've been doing here to leverage data and specifically clinical data, including EHR data, to help drive performance in risk-based contracting. So we'll start off a little bit talking about what BIDCO is and who we are. We're a value-based physician and hospital network. It's a joint structure located in Massachusetts, but our market is really eastern Massachusetts. We've got about 2,500 physicians, and we are affiliated with Harvard Medical School. Our ACO risk population includes there's commercial products, Medicare, and Medicaid. We just went into the Medicaid ACO this year, and that's been a challenge. Our mission is to move healthcare forward by engaging providers in their communities to achieve success in value-based delivery systems. We are committed to creating innovative, industry-leading best practices in the clinical, administrative, and financial aspects of healthcare. I have to read that one verbatim. That's the rules here at BIDCO. So again, this is where a map of where BIDCO exists. If you look at here, we're mostly saturated in eastern Massachusetts. We've got our hospitals and our physician groups. We have hospitals in the northern region, Metro Boston, and what we call the Cape area. And in our structure, there's a hospital organization with a risk-sharing partner that is a physician group. So it's a 1-for-1 ratio. There's always a hospital and a physician group that are tied together. So a little bit real quick by the numbers. Again, I said 2,500 physicians. I round the numbers because that ebbs and flows on a regular basis, but approximately 600 primary care physicians and 1,900 specialists. Again, the total covered lives that people we have at risk is approximately 225,000. Again, that fluctuates depending on membership. And it's broken down there, as you can see, the various contracts that we're in. We do have a 100% EHR adoption rate across our network. In fact, it's a requirement of BIDCO membership that you have a certified EHR to be a member. And we have, unfortunately, 46 different EHRs in our network, which is really, kind of the gist of what we're really going to be talking about today, which is, how do you deal with that and leverage that data. But what that really amounts to is about 150 plus individual EHR systems and vendor installations across our network, in about 300 plus geographic locations. And probably most importantly, we've got 90 great employees here in Westwood, Massachusetts that support BIDCO. Some of our accomplishments in the value-based care continuum have been we were ranked the #1 pioneer ACO in Massachusetts and #3 nationally. We were the top performing ACO in quality in 2015, I believe 2016. We've had some really good accomplishments around improving patient outcomes and reducing costs, doubling the rate of performing fall risk assessments, tripling the number of patients who received depression screenings. And again, this was leveraging our EHR network to be able to do that, along with some savings. So again, trying to go through that triple aim to get to where we're going with is, keeping patients healthy and safe, as well as trying to reduce costs. So let's talk a little bit about how we got there. And, what I'll say is we're still learning every day how to do this. It's certainly, I don't have a magic bullet solution other than, sharing what we've done and what we're able to do to get some successes. So I, call this living the transformation, or how I learned to stop worrying and embrace data chaos. If anyone knows, that's a Dr. Strangelove reference. And so let's talk a little bit about the contracting continuum, right? And this slide really kind of shows what that looks like from, the financial reward as it aligns with the risk that you're taking on, right? With fee-for-service being, low reward, low risk, but pretty straightforward, up all the way to upside, downside risk and capitation, right? And that's where you're taking on the most amount of risk, but the highest potential reward as well. And I think that looking at this map, from the BIDCO perspective, we've kind of gone through the shared savings, and we actually did some pay for performance back around 2010, 2011, moved into some shared savings, and now we are in upside downside risk in most of our risk contracts. We're not in full capitation just yet, but we are in full upside and downside. We haven't really embraced bundled payments yet, and the only reason for that is the bundles presented to date have not really made a lot of sense in our particular network with our hospital physician membership. So that's not to say it's not a worthy thing to go into. We just don't have a lot of experience in the bundle payments because it just hasn't worked in our network. But then, the real important thing here to note is that, where you're going along that trajectory of risk versus reward. And that sort of ties into the next slide, which is the sort of IT transformation roadmap. And, this was the federal government's, health IT strategic plan, which was really starting around how do we get how do we use information technologies in the communities to better transform healthcare and, ideally keep patients healthy. So, along this line, while some days I like to think we're in goal 5 already, some days I come in and I think we're, we're still in goal 3 or 4. But ultimately, I think this foundational map, which really kind of includes meaningful use, and meaningful use being that program that gave the ability to get EMRs out into the communities so everybody could have access to these tools, which is a foundational component of how you can leverage that information to drive change in and being able to perform in a risk contract. But that's where we really get into some of the difficulties in what can happen. So, what we really have here is kind of what I call clinical data chaos, right? In particularly in our network, and I think talking to a lot of folks, while there's still there are a lot of systems that are single EHR systems. Most people I talk to, they still have some groups that are on other systems outside of that single unified system, And I've seen cases where people just say, we're just not going to do anything, we're not going to deal with that data. And I think you can. There's ways you can do that, but it is understanding what the problem is, and that's the fact that all of these EHR systems do things differently, right? So the data resides in all of these unintegrated systems, and probably, is the nature of that data and how it's delivered is kind of where the crux of some of this challenge is, right? So I like to break data into 4 categories. Traditionally, you hear about structured and unstructured data, and the reason I say and beyond here is we kind of look at it in 4 components. We call it structured and coded data. That's really the good stuff, right, the holy grail stuff. But the reality of that is in our network with so many different EHRs, that only represents about 5 to 10% of the data that we're pulling in from the EHR systems and the various clinical systems. The next category I like to call structured and uncoded. That's where you have structured data elements, but you've got elements in there that are not coded or sort of normalized in any way that you could use. Then the next category after that I like to call unstructured but coded, and that's where you have unstructured data elements that you've got to sort of pick out and see what you can use. But you do have some coded elements, like maybe your pharmacy and your RX norm or your NDC codes are there, and the coding is quantified and you can use it. All of those 3 categories probably represent about 30% total of the data that we're pulling in on a regular basis. The remaining 70% is the unstructured, uncoded data, and there's a lot of opportunity in there. And a lot of that depends on, how you can leverage that information and what you're trying to do. These days, we're trying to look at some machine learning capabilities to improve upon that. But the other challenge to that is, when you're trying to use these EHR data platforms, these vended systems, there's frequent regulatory and contractual requirement changes. And being able to leverage that data and use it while those things change, it becomes a manual process that you've got to, you as an ACO have to figure out how to deal with. And that's probably the biggest part of this journey and challenge, is getting the groundwork done to understand what you have to do and create a repeatable process, which you'll hear me say many times. And then ultimately, each one of these systems, they have very transport and payload delivery mechanisms, and those can really impact, as we'll see in some later slides, what the data you get and how usable it can be. Every one of these EHRs, they may deliver you a CCDA, but that payload of what's in that CCDA will vary from vendor to vendor. And you've got to understand that, because when you go to aggregate that data from EHR to EHR to EHR, that aggregation and normalization process can be challenging because of that variation. So just to give everyone an example of the chaos that we're talking about, this slide here, really what we're concentrating on is the red circle, right? So this is from the Certified Health IT product list. I pulled this in August, this image. It's probably changed, but 195 different vendors are certified in the CERT 2015 program. So that doesn't even include the folks that are still, the vendors that are still on 2013 trying to get to 2015. 195 different clinical systems that are potentially in your network that you've got to figure out how to, do something with that information. So that's quite a challenge. And unfortunately, it's not as easy as this, right? A lot of folks just figure, all right, well, it's just another interface. It's just another data feed. All we have to do is connect those pipes, turn the data on, and you're ready to go. And, unfortunately, when you look at a network like ours with a lot of different clinical systems, even if you have just a handful of clinical systems out there, EHR systems, you still have to connect all of those and do some, they're different versions or different installs. You've got to do some normalization there. The reality of this is it looks more like this. Lots of different connections, lots of different delivery mechanisms and payloads that you've got to figure out how to normalize, quantify, and validate. So it's a lot more of a challenge than I think folks realize. And while data folks realize this, sometimes convincing your leadership of what the challenge and what the roadmap might be, that can be, just as much of a challenge as getting this done, because in many ways folks view this as, oh, just connect it and you're good to go. So let's, move down the line there and, say you get all your data connected, you've got all your systems in place, you've got all your pipes connected and you've got the data flowing, right? So that was me, this guy on the slide, that was me in around 2012, 2013. We went out there, we got a good number of our systems sending data to us. We had figured out how to deal with different payload delivery mechanisms. We were using CCDAs, we were using C32s in some cases, we were using some flat file specs that we put together. We were also using an ability through a third-party vendor that allowed us to go in and actually extract data from an EMR. But we pulled it all together and we thought we were good to go there, but this was our reality, right? The data really wasn't usable because it was so disparate and different and not normalized in any way. So this is really where some of the challenge sits. How can you use that information? What programs can you put in place that will allow you to leverage this very rich and robust data that has a lot of value, right? If you're going to drive your organization, your ACO, trying to perform in an ACO solely with claims data analytics just isn't going to cut it, right? Because your data from your claims is 90 to 120 days lagged. Your EHR data, that's available to you within a 24-hour period. And there's different mechanisms of how you get it, but you have a potential to have impact within 24 to 48 hours, whereas on a claims environment, your lag so far, you could have had patients that showed up in the emergency room 2 or 3 times in that amount of time, and you wouldn't really know about that without some of this information. So how do we make sense of this data chaos? There's the ability versus reality of useful EHR data capture, and the crux of that is understanding what's going on at the practice level. You can't really do this sitting in a central location just analyzing the data and determining what you need to do. You've got to really come up with a program to get out into the practices and understand the workflows of those practices and try to impact that workflow in a way that allows you to capture the data that you need. All of these systems, as I say, they store the data differently. You've got to figure out those transport mechanisms. You've got to figure out how to normalize all that information and when it comes in. And there are ways to do that. But it is a journey to get there. And it does really rely on getting out into the community and working with your practices. There's no fully embraced health information exchange standard right now. Lots of different states have different ways they've approached HIE and HIE platforms. In Massachusetts, it's not a data repository. It's really a secure transport mechanism and a secure address list that allows you to exchange information, but there's no storage of that information. The vision of interoperability is still not achieved. This fragmented access to EHR data. There is the vendor support's lacking insofar as, I think vendors are doing the best they can to provide information for their customer base, but that's solely to their customer base. When you're really talking about wanting to interoperate information, exchange information from provider to provider on different EHR clinical systems, there's still a lot of non-information out there, and you've got to figure out some of that yourself. And we've done a lot in our network where we've built our own capabilities to provide interoperability while some of that interoperability is still being developed and understood. And then, you've got your data mapping normalization, and that's where your real big challenge is right now in trying to make something like this happen. You've got NDC codes, RX norms. Every one of these systems could have a different code base and deliver that payload in a different way. We even have an EHR in our network that stores medications both in RX norm and NDC codes. Like, why would somebody do that? So we have to do a normalization and mapping exercise from within a payload that comes from a single EHR. So there's some places here where I think, you know, we've got to do better as an industry, excuse me, to get a better handle on this data. And then we have the other challenge with competing quality measures, priorities, and contracts. You know, there's no unified reporting mechanism, and we'll talk a little bit about that later, but you've got to report to all these programs, and you know, they all want it in a different way. They, you know, Blue Cross Blue Shield might want their hemoglobin A1Cs calculated one way, and MSSP or, you know, CMS wants it calculated in a different way. And in order to do that, that burden really falls back on you, the ACO, to come up with a way to look at that data and deliver those results back and those calculations back on an individual, you know, possibility. What we need is some standards and unified quality measures that leverage the EHR data. So real-time performance reporting, fact or fiction? I think it's fact. It can be done. We're doing it now. We've been doing it for you know, a number of years, and we have different ways that we've gone about doing this. So we'll start where, you know, back in 2012, when I thought I was the happy guy in the slide there a few slides ago, you know, this is where we were at that point, and that was finding data discrepancies from these various clinical systems in the way we receive the information. We have a clinical data warehouse which you know, contained solely clinical data information in a data repository. So all of our EHR systems were sending data to that quality data warehouse. How the data was getting there had various mechanisms, as I described. You know, in the slide here it says CCDs, but it was a mix of CCDs. We had C32s, we had CCDAs, and again, as I said, all of those payloads and all of those transport mechanisms were slightly different. We even had, like I said, we had some flat files that we were using because we had some vendors that couldn't deliver a CCD. You know, if you go back, I mean, my hope had in 2012 had been, well, meaningful use has a requirement for interoperability with a CCD, and that was going to solve my problem. But the reality is this payload and transport mechanism factor, you know, has a huge impact on how usable that data is. And then we have the claims data feed going into a separate data warehouse. And where we wanted to be was a place where we had all of that data merged. So how do we get to this place where that data is flowing and it's clean and it's usable and it's great? And, you know, I think this is where the journey starts. We really wanted to look at how to improve the data quality in a rapid way. So what we did was we looked at using some third-party capabilities that allowed us to actually extract data directly from EHRs. And that was a huge boon, because instead of historically where we would have to look at how was the data being documented, tying that back to the CCD and understanding what data elements were actually contained in that payload, right? If you think of something, you know, if we look at that top line where we have CCDs going directly into our clinical data warehouse, thinking about that, you would have to make sure that when a physician was or a clinical person was entering information into the EMR, that what they were entering and what discrete data elements they were choosing were the ones that were being packed into that data payload. And what I mean by that is, you know, you could look at something like, you know, a particular EMR might have 6 different ways for you to document a diabetic visit. But only one of those ways is what ends up in that data payload based on the vendor's CCD specifications. From the EMR perspective, from the clinical perspective, you could document in any one of those ways, and that information is there in the medical record and usable at that local level. But to make it be usable on an aggregated network-wide data platform level, you needed to make sure that the right mechanism was used to capture that information so it ended up in that CCD data payload. So what we really did was really look at the ways to improve those payloads and those delivery mechanisms so that we could maximize our potential on data. At that point, we hadn't merged our claims and our clinical data together. They were still separate, and we were doing some of that on our own. And that brings us to kind of where we are today, and you know, we're still adding to this, and that's all of our data is in a single data repository, while all of our data, clinical data, still flows to our quality data warehouse. It's immediately merged into our new population health data warehouse platform that has our claims data as well. That contains our master patient index, merged claims and clinical information, so you're no longer looking at a view of claims-only view or a clinical-only view. You're really looking at a merged example of that. Our measure calculation is happening at that place, and we have multiple ways of reporting, whether it's reports that we generate through back-end reporting or a web front end that allows people to go in and see real-time what's going on. But probably the most important piece here is the real-time capability, in that we're getting the data from all of our EHRs into our data repository, into our data warehouse, merging it with the claims data, and that's happening on a weekly basis. We're getting some of our clinical data is coming in on a nightly basis. Some it's taking a couple of days longer based on a vendor's inability to deliver the data to us. But some of it is happening, the least amount of time. We only allow a maximum of 1 week on a data delivery. If a vendor can't do that, we don't allow that EHR into our network. But we're getting the data real time. It goes in, and then when we do a data refresh on the front end, that data is lagged about a week. What that allows you to do is look at claims data and then what we call the trajectory of information. And that's the ability of using that real-time clinical data to drive a directional component of where you need to go to fill gaps in care, understand utilization, because ultimately it really does matter what happens with the claims, because when the claims come in and we normalize all of that, that's when it tells, from the payer's perspective, it informs you what the payer thinks really happened. And that's important to know, because you can have a situation where something's being documented in EMR and you're getting that clinical information that's showing that something of a visit, a diabetic visit have occurred, or cancer screenings occurred, but the payer doesn't recognize that for some reason. And it can be anything from it wasn't coded properly to we've seen things where bills just didn't go out the door. It was documented and coded and put into the billing queue, but it never went out the door. So from the payer's perspective, that cancer screening didn't happen, and then you fail that quality measure. So it's really important to understand that EHR data is going to give you a direction, but when you load in that claims data on a quarterly basis, and it allows you to true up and understand where things really are. So that's an important distinction to understand. So as I said, and I keep saying, the journey will be difficult as we see our friend Samwise Gamgee on his way to Mordor. And it will seem somewhat insurmountable in some ways. But it's the type of a journey that you just have to start taking a step forward and not wait for perfection, because you'll never get there with this kind of information. In fact, I'd say even if you're 50% accurate with some of it, start the work. And just be very communicative with your network so that they understand where you are with things. An example I would use is at one point we were aggregating our information in a care gaps report, and of the I think 18 measures in a particular contract, we only had solid data we felt we could stand behind on 12. So we were only showing the network those 12 gaps in care reports. We weren't showing them the ones that we knew were not ready for prime time. So it's really important to know your data and be able to stand on it confidently, but it is something you've just got to take the time and start working towards. It's literally one step at a time. And have a process that you're trying to repeat. And it's locate the information, normalize it, codify it, map it, validate it, improve it, and rinse and repeat. And that validate and improve, that process really involves your customer base, your physicians and your practices, really your quality leads at the practices as well. Making sure that you understand what they're trying to do, how they're documenting, but also that they understand what you're doing with the information, so it gives them confidence in the data. because the worst thing you can do is put out information that is not accurate, or not accurate and you didn't realize it wasn't accurate, because if you do that, you'll immediately lose confidence on your customer base, and they won't really trust your data again. But what's interesting is that when you do this, in our network, the only people that ever come to us and say our data's wrong at this point are folks that are not performing well. I've never had someone come to me and say, "Gee, Bill, your data's wrong because I know I'm not performing that well in your network." That never seems to happen. It's always the lower performers. But the important thing is to make sure before you release this stuff for prime time that you've got the confidence in the information you're putting out there, and making sure that you can stand behind it and follow the breadcrumbs back. That's not to say that problems won't be found. You will find information, and it's again opening that bridge of communication with your customer base so they understand what you're doing and what you're delivering back to them. And then develop a sustainable, repeatable process. This slide here we put together probably around 2012, when we really were looking at how can we do really well in the Pioneer program, leveraging EHR data. So we came up with this process of starting at the practice, starting with the providers, understanding what their workflow is, how they're documenting, how the data is getting to our repositories, validating that information, what we're delivering back, making sure what we give back to the practices has value to them, that it's actionable in a way that they can actually use, not just a giant report that no one's really interested in and ends up in the bin. It needs to be something usable for them where they can see wins and results. And then training, going back and educating those practices and the quality leads and the physicians on proper documentation, understanding the various components and quality measures and what's important, and why we have to capture things in a certain way. And then it's a rinse and repeat. You're still going back and looking for the feedback, making changes to the data. This is an ongoing, never-ending process of improvement. So what are some of the opportunities for transformation? I think that, again, EHRs provide that, real-time structured clinical data capture, right? We have this real ability, because of meaningful use, to leverage that foundation that's been put out there and use information that's captured on a daily basis. And, understanding what those triggers and mechanisms are, but knowing that you've got this information, it can be a real catalyst for change. It was here at BIDCO. We sort of built our foundation as a network when we became an ACO around that clinical data information, that we wanted to build a program that leveraged real-time clinical information that sort of provide directionality and trajectory on the overall performance from the payer's perspective. We built our quality data center. That was our clinical data repository, where we aggregated, and we still aggregate, all of our clinical, lab, and scheduling and ADT information. Then that flows into our master population health data warehouse, where we merge the claims and the clinical data together, and give us a really good lens on what's going on at the individual patient level. And that really drives our care management programs as well. We have a care management program here at BIDCO where we assign care managers to folks in high-risk care programs, comorbidities, and so forth. And having that ability to see what's going on real time has really helped that care management program move along. And again, moving away from the lagged claims. I don't think you can really succeed in a value-based care model just using claims information. You've got to understand what's happening day to day with your patients, so you can get in front of them, assign them to care management programs, make sure there's someone speaking to them when they're discharged, find out why they end up in the ED a few times, why are they frequent flyers. Having that information real time is really going to help. And now we're looking at public health information and just publicly available census information, mapping that into our population health tool, and looking at geomapping populations and diseases based on demographics and various social indicators. And we've put together some programs. An example is, we had a program where we looked at some of the data and found a high density of onset diabetes was in areas where there's a high density of fast food restaurants in lower economic regions. So we looked at that and said, well, this is about nutrition education. We put together those programs to go out and try to educate those populations about proper nutrition, get them aligned with, programs that could help them feed their families in a more affordable way. And we actually saw some turnarounds and some improvements with that. So that was just a quick example of what you can do when you pull all of this data together in one place and start to see things from a different lens than you may have had before. And then there's all the self-reporting information. I think from my personal perspective, I think like last year, 2 years ago, it was all about can we get you the patient's Fitbit data? Can these patients provide that to us? I think we're going to move past that and really move into things with items, technologies like Alexa, and having those in patients' home and allowing them, to have Bluetooth-enabled, blood pressure and blood glucose monitors and scales, as well as the patient reporting what's going on with them directly to Alexa, and then that data comes back to us in a way that we can actually use that. At BIDMC, they're actually doing some pilots with this right now, and it looks very promising. So I think we're going to leapfrog over the actual individual data components that are patient self-reported and maybe jump into a newer sort of, I'll use the fancy term, AI-based options. So our approach, really, our data integration approach was, identify those main sources of data integrity flaws. Understanding your EHR, what's in those payloads, what can you do to improve that from the physician quality manager practice side to make sure you're getting the most robust data you can get. Develop a technology-based solution, understanding your own data, your own sort of network and what you need to do, and, do you need a separate clinical data repository, or maybe you want to just merge it all in one place, but understanding that information and the technology and where those flaws exist so that you can have the most impact on where to go. Third, really apply and adhere to data governance. If you start off with a foundation of data governance, I think you'll be much happier down the road. I wish I had done that. I'll be honest, we didn't. We sort of went in, jumped in both feet, and kind of added data governance after the fact, but I think if you do it up front, you'll find yourself to be a lot more successful, and it'll be make a lot more sense for you. And again, for us, the solution is developing a standard repeatable process that allows you to leverage that clinical data. Find where it sits in the EMR, make sure it's documented in a way that you get it. When you receive it, normalize it, codify it, map it, unify those into your data construct, validate it, make sure you can stand on it before you deliver things at the practice setting, at the physician setting, and improve. Learn as you go along and make changes and communicate with your membership and make sure that they're on board, and look for better ways to maximize your data capture opportunities. And then, qualify, having a quality data foundation. A lot of people want to focus on the left-hand side of this slide here, which is building the data asset. That is very important, having that data asset. But it's a three-legged stool. You've got to be transparent in your data quality, making sure that you can stand on it, as I said. You understand where you're getting it from, that it does meet what you're trying to drive, and then you're producing something that is usable by your membership. And when I say usable, it's not just the information itself. It's presented in a way that makes sense to them and allows them to create programs within their practice to have daily huddles with who's coming in today, and let's make sure we get those cancer screenings done, or do we have all of our annual wellness visits done. It's having that information at your fingertips and knowing where you are, and making sure that you're not delivering something that isn't of use at the customer practice physician end. So how can we improve this journey? I talked about this a little bit. If there was some, in my ideal world, if we could have, say, 100 possible quality measures that all payers had to pick from, that was all agreed on and had standard calculations and standard measurements, And then vendors could really design their systems to deliver this data from day one to you as an ACO with a standardized transport and payload that was usable right up front. Unfortunately today, the burden is on us as an ACO to do all that manual work and do all of that. But that doesn't mean we can't, as an industry, all sort of think to what a better future might be. Some other things to think about, like, high tech, that came into effect, HIPAA and high tech, the high tech portion of HIPAA, really before ACO, right? Before there were some, we were in a P4P program at that time, but really it predates the ACO world. We look at high tech, the RFC was in 2008. It was adopted in 2009. It was some of the concepts in there really impede the ability to have this data flow and easily and nominally to an ACO to make them successful. And something like covered entity status for an ACO like us that don't bill, I think is a place where that we could see some improvement. National patient identifier, I know that's a hot button topic, and but I think that in order to really have true interoperability across the country, we need something beyond localized EMPIs. You need to have some sort of identifier that comes from the national level that we all agree with. And again, shake off those HIEs that you have available to you and get them to offload some of this work that right now sits squarely with you. So steps to innovate. Don't be afraid to move away from what's not working. Define the successes at each stage and celebrate all the wins. Make sure if you're not 100% there, that's okay. If you're making progress along the way, and celebrate those wins, that's important. Get your teams armed with all the right information and anticipate where things are going to go, not only with your network, but where things are going from the payer and contracting perspective, and that also from the federal level as well. Invest in the right hardware and architecture. Find good partners that you can work with that really support you and give you your strengths. They support your strengths and offset some of your weaknesses. And again, incorporate that user feedback. Understand, making sure that your customers are getting the information that works for them and that you're getting all the right information from them. And I'd say most importantly, don't reinvent the wheel. At this stage of the game, there's lots of vendors and systems out there or folks with the talent that can help build a lot of this stuff. You don't need to build it from scratch. And I think if you try to build it from scratch, you'll find yourself mired in complications instead of driving towards success. So in summary, this will help when your providers better understand their patient population. It really helps with interventions, and it improves health outcomes, but also drives down the cost of care. So that's really, what we're trying to do as an ACO. And in our case, everyone gained confidence in the quality of the data, and that's no longer a question. They sort of take what we send to them and understand it really helps them improve their practice. So with that, I'll turn it over for any questions, and I hope this was relevant for everybody.
Thank you so much, Bill. We do have a few minutes left for our question and answer segment. If you do have questions that arose during the presentation, please feel free to submit them using the question tool to the left of your screen. Our first question is about the 4 categories of structured and unstructured data that you mentioned. You said that about 5 to 10% is the holy grail of structured and coded data. The question is, should you try actively to increase the amount of structured and coded data that you produce at the EHR interface level, or should you work more on, connecting those pipes in the back end to make use of all of the other types of data? Where is the balance point between those two things?
Yeah, that's a really great question, and I think as much as you can build that structured coded data, that's where you're going to find your real ability to use this information right out of the gate without a ton of normalization work on your end. So if you can go and work with your practices, make sure they're documenting in the right place, in a place that's a structured location, and some of this depends on the EMR vendor, whether they're codifying some of this information or not. But that, as much as you can have things fall into that bucket, that's the best place to go. The reality is, it's a journey. You can work things from unstructured and coded up through the map by doing some iterative processes at where the data is captured. There's not a lot of ability to do that on the back end other than in the pure unstructured encoded, I think that, like I said, we're working with some groups with some machine learning capabilities to help us get through some of that unstructured encoded data, because it's rich with information, but it's a gargantuan amount of information, and it's more than can, at least in our network, than could be done from a manual process of someone sort of just being able to, sift through it and try to find it. But ultimately, try to get that data as clean as you can get it. That clean water flowing, that's where you want to go. As much as you can get that, that relieves that normalization burden from you and codifying it, and allows you to just concentrate on the results.
Our second, well, actually 2 questions build right off of that topic. The first is, how many payers, different payers, aside from CMS, do you receive claims data from? And associated with that is, do you incorporate data from financial and operational systems as well as your clinical and claims data?
So we do receive claims data from all of our all of the risk contracts that we're in. So I think we're in about 8 different contracts with various claims functions. So commercial payers, Medicare, Medicaid, we're getting those claims feeds directly from the payers. So as far as we integrate the data from the financial and operations system, so I think when you mean like billing systems, I'm not sure exactly what the question is, but we do not today, but we are looking at integrating billing data. BIDCO itself does not bill, so we don't do any billing here, and that leaves us short in some aspects. Now, some of you folks might do the billing, and that will actually help you, right? Because then you'll have a leg up on what you think would have gone out the door, and you can actually tie that to that clinical data earlier than just waiting for the claims data to come in. So what we're looking to do is not necessarily looking at the data that went out to the billers, but we're looking at what went out on the charge capture from the EMR and incorporating that back to the encounter to try to determine where things really sit. But I think that's a great place to where you can get some leverage and improve your data, improve your sort of lens on what's going on with your population. So I hope I answered both of those questions for those 2 folks.
Our next question is about governance. You mentioned some organizations may face challenges with executive buy-in and really disseminating these ideas throughout the organization. So what kind of governance, data governance structure do you have? What kind of committees does BIDCO use to make sure that everyone is on the same page?
So we have a data governance subcommittee, and it's local here at BIDCO, and we have executive leadership. I'm the executive sponsor for that. I'm on the senior leadership team at BIDCO. Then the information and the governance programs that we put together and how we want to deal with data, I report back to our senior leadership team and to our board as to what we're doing with our various data programs. As far as getting the buy-in, what I mean by the buy-in is sometimes, getting this data connected and usable requires a team of folks. It's not as simple as, there's a perception for folks that aren't in this data game to think that it's just an interface. It's just like a lab result. It should be pretty easy to do, and it's far more complicated than that. And you need to have the right staff on your side to do that, and convincing your leaders that by having the right people at a salary cost could reap huge benefits on the reward cost. When we look at that, thinking of that slide of risk versus reward, there's great potential to bring in millions of dollars with the right folks getting the right data elements at the beginning. Like we have a data scientist on our staff, and I think that's a key component, having someone that can really pull that data apart and come up with ways that you can use it.
Our next question is, do providers have direct access to the QDC data, or does BIDCO manage it and then disseminate that information? And if that's the case, how often do they do that, and are there a lot of questions about it?
Sure, that's a really great question. So the QDC, which is our clinical data repository, we don't allow access to that. It's only really accessed by us. Other than, just to clarify one small point, we do have some canned reports that people can pull down from there. And it's really based on history. When we were really starting down the pay for performance and the pioneer road, we wanted to give folks the ability to look at that. Today we have them really look at our population health system, which has a web front end. It's easily accessible. It can allow them not only to look at canned reports, but they can look at information using some pretty robust filtering and create very detailed reports at the what we call the pod level. That's where we have groups of physicians organized together. They can look at the practice level right down to the physician and patient level. They can really do that on their own through our front end. As far as who's using that, we've got folks that are really well versed and jumping right in and using it. But I would say we're still getting the education out there on the use of this front end. So folks are still relying on the reports that we give them. But as we do that, we're trying to educate them that this information is available for them to use and leverage right now. And that education process, as you can imagine, it will take some time to really get it disseminated out there because it's a very powerful tool, and you start to get into some of the advanced filtering, and it takes just some time of folks getting used to it. But I think the other part of the question was around, did they have questions about the data? Absolutely, especially at the beginning when we were first rolling out this information. In fact, I would say that the biggest feedback we got was the data's not right, and these are the 10 reasons why, or I'm at the lower end of that because I have a higher risk population. I've got a sicker population. And what I was saying, you've really got to have your foundation there and be able to stand on that before you release it. Because if you release it too soon, or you release it too soon without explanations of things that aren't going to be right, you won't get buy-in down the road. You've got to make sure people are confident in that information because, as I said, if you've got folks performing in the lower end of quality, for instance, if they have questions or don't believe in the data, you're not going to be able to get them to drive change using that information in a way that makes sense because they won't believe what's going on. And as I said, I've never had anybody come to me and say, gee, I'm not really performing that well. There must be something wrong with the data. So as long as you're solid on the data, usually you can find your way back to and explain to those folks that question it, being able to show them one for one, here's why, this is the reasons, this is going a certain way, and here's the data to back that up. And I'd say 98% of the time you get the buy-in, right? And then you get the confidence because they see that it's built on a foundation that's solid and it doesn't have a bunch of holes in it. So that's a critical piece, though. Don't get your stuff out there too soon if you're not ready.
Along those same lines, our next question is about drilling down into that data. So when you give a provider, a reporter, access to the portal, do they have access to metadata, or how far can they kind of drill down into their metrics and what's supporting the surface level that you're providing?
They can drill down pretty far with our front end now, but it's certainly not like back-end access that we have folks here doing today. If people want to have really deep drill down, and this tends to be less on the quality side and more on the what I call the medical economics side, where we're talking about TME and utilization. That's where we see folks wanting to do some deeper drilling. We use Tableau reports for that, so we generate reports that allow them to go in and sort of get a refresh in real time for what they want and allow them to drill into some of that information. And because those Tableau reports are built off the back end, it's a much robust data set with a lot of metadata, whereas the front end is more discrete data elements that are available. But it still has a lot of power, that front end. And what we've found is that 90% of the folks, that's all they really need is that front end drill down capability. There's just a handful of folks that want to see some really robust information. When I say folks, I'm talking about our physician membership. Talking about executive leadership and folks like that. Yeah, they tend to want to have more of a drill down, and that's why we have the Tableau reporting of beyond what we deliver at a hard copy on a regular basis.
Our next question is about collaborating with payers. and sort of how much deeper does the relationship go besides getting access to claims? Do you collaborate around, when you make an improvement or you hit a milestone, do you talk to your payers? Do they talk to you when they have new data sources available? What's the relationship there?
We try to be as open as we can with the payers, but I can't say that the relationship is generally more than, here's where you're performing, and the payers have their own reports of how you might be performing in quality or utilization, and we have to tie that back as well. And one of the data elements we actually pull into our warehouse is the quality files from the payer's perspective. We integrate those in and marry those in, but a great example there is when we find discrepancies of patients that being dropped into the wrong numerators, and trying to work with the payers to say, you've got this person in our numerator and they don't belong there, they don't qualify that for that disease, and here's the reason why. An example might be someone that had a double mastectomy in their history, but being listed as not having a breast cancer screening in that quality performance year, and having that dialogue back and forth and giving that information. What we're finding, though, is the payers are now starting to trust our data, and they're actually asking us to provide them with the data because we have this rich EHR data set that can really help them manage their patients as well. But again, it was a journey, getting them to understand that the information we got was, had value and was valuable. What I'd like to see more is more flexibility from the payer perspective on those quality measures and various components of a contract. We try every year or whenever we're doing a negotiation to make them all kind of similar, but we don't get a lot of bites from the payer side. Maybe other people have had different experiences, but ours have been, they're very fixed on what they want to do. But I think if we had more unified, standardized measurements across payers, it would allow the EHR vendors to deliver a product that would do some of this for us. But today, I think their hands are tied. The vendors' hands are tied by what they can do based on there's just too many options out there.
And speaking of options, our last question is about the idea of a single data warehouse as kind of an aspirational goal. Are there other ways to organize your data storage and warehousing architecture instead of maybe having to rip and replace what you have and kind of put everything into a single repository location?
Yeah, I think you could definitely achieve similar goals. I mean, we just started our, we're in this single unified platform now. We began the journey about 2 years ago. But before that, we had about 6 different data sets that we were using to perform a lot of this information. You could definitely do it, but the burden falls back on you to get all of that information back and having the right teams to look at those disparate data sources and develop information in a way that meets your customer needs and your executive team needs going forward. In our case, when we had the disparate data sources, we were generating data marts, doing a lot of normalization and merging the information from those together. But it was a lot of cramming and mashing information together. Brute force. It was a brute force methodology, but it can definitely work. And I think this ties right into what I was saying, that don't wait for perfection. Start with what you got and make some changes. Look at maybe not do every quality measure, focus on like the 3 heavy hitters in your network and say, we're going to use clinical data to drive improvement on these specific measures. And those measures could be ones you choose based on financial reward versus, or looking at things like, I might need to bring in 4,000 diabetics, or I could bring in 6 children for well child visits. Well, let's get those 6 kids in and get those done. And that's being able to analyze that data and understand what's going on in your network.
Well, thank you. That is all the time we have today. I'd like to extend my special thanks to Bill for his wonderful presentation, as well to Looker for sponsoring this presentation. The webcast will be available on demand at healthitanalytics.com if you wish to review the presentation or share it with a colleague. For the latest news and information on data analytics, artificial intelligence, population health management, and data governance, please visit healthitanalytics.com. Thank you for attending and have a great day.